Report in the Cloud. And as I mentioned, we are going to be hosting different topics monthly, including orthopedics, cardiology, physical therapy, cancer care services, and we'll be featuring our local physicians. As just housekeeping for Zoom, I know a lot of you are probably very well aware of how Zoom works. I have muted everybody upon entry, so everybody is muted, but you can certainly unmute yourself during question and answers. And again, in the chat feature, your questions will come directly to me, and I'll kind of handle those as we go. Today, we have Judy Newland, our COO and administrator at Incline. We have Harry Weiss, our CEO, and we have Beata Schopp. Beata Schopp is our infection preventionist, and she's going to be sharing her screen and sharing a PowerPoint about some of the facts related to COVID, the details, the data around our statistics here locally, and really as we go into flu season, what that could potentially look like for our region. And I do want to share again that some of you supported the COVID campaign, others of you have supported our hospitals in general, and what a difference that has made overall for our health system. We truly appreciate it. During this time, it's been a very challenging time in healthcare, and those dollars have gone very far in order for us to support our ability to care for our patients in the best way that we know and you all expect. So how we're going to structure this is we'll have about 5 minutes from our leadership team, just giving an overview. Then we'll go to our presenter. She'll have about 20 minutes or so. Then we'll have a Q&A, and we're going to try to keep our whole presentation to about 45 minutes so that people can join in their lunch hour and then get on their merry way here. So I am going to now turn it over to Harry Weiss, our CEO and president of Tahoe Forest Health System. And Harry, if you need me to unmute you, but you look good. So I think we're good to go.
Good afternoon, everyone, and thank you for spending a little bit of time with us today. We really want to thank all of our community members from our various regions that have really stepped forward to help us philanthropically during really an unprecedented time. Healthcare has never been affected probably as much as it has this year since the Great Depression. I think that's a statement even the Mayo Clinic made several weeks ago. So it's been kind of unprecedented, certainly probably since the 1918 flu, it wasn't handled in a similar way either. So we certainly appreciate the philanthropy as healthcare all across America has really struggled. They estimated that hospital systems across America were losing $40 billion billion a month in revenues. How this public health crisis has been handled this year. So it's kind of the first time since 1918 where hospitals were really asked to focus on one health or disease issue and kind of as a lesser priority focus on all other diseases. And so that's a topic I've been talking about, that really all diseases are important and really need fair and timely attention. Mayo Clinic and Cleveland Clinic have come out on June 9 similarly. Just to give you a little bit of a backdrop, across the U.S., we hit the peak in average in new daily COVID-19 cases back on April 24. In California, it appears we hit that peak on June 12, so we've been ramping up much more slowly. So June 12 was the peak in the quantity of new daily COVID-19 cases in California, and all the way back to April 24 for the U.S. I tried to find it for Nevada, but because the number of cases are so much smaller, I couldn't get the graphics that I was looking for. We're now seeing across America about half the number of new, even though there's tremendous COVID-19 lab testing, we're seeing about 20,000 new cases a day when we were seeing almost 40,000 new positive cases a day back on April 24. the deaths reached their peak relative, and this is across all America, on April 21 at 2,693 for a single day, and on June 15, it had fallen 1/6 of that to about 425. So yes, we are seeing ebbs and flows all around us, and Sveta can, share those kinds of things, but I just thought I would share that with you. I'll just cover inpatient census very briefly. We were advised by outside organizations that we could expect a huge inpatient surge, huge being in the hundreds actually, and our April census ranged from 0 to 7. May was 0 to 4 inpatients, and June so far is 0 to 3. So one of the things I think that's a core adage, and I think it relates to the kind-heartedness of each of our donors, is that we all agree that timely access to great health care is one of the most precious gifts on this earth. That's certainly my adage, and that's why I personally donate to Incline and to Truckee, because I want to be a small part of that guarantee that great health care is always going to exist in these communities. I don't take it for granted at all. So we really sincerely appreciate your help and participation, and I'll turn it back to Carly.
Sounds great. So I am, one thing I forgot to mention is we also have Laura Lasco on the phone, and she may be extremely helpful for us when we get to Q&As, because she's our director of lab. So if we have questions around testing, she'll be able to address that. But I do want to give Judy Newlands the opportunity to say a few words. She's, again, our COO of the health system and the administrator of Incline Village Community Hospital.
Unmuted. Thank you all for being on this call. It's actually really exciting to see all the wonderful faces and names. Again, thank you all for your support of Incline Village Community Hospital and Tahoe Forest Hospital during these challenging times. I cannot tell you how much we appreciate your support. It has made a difference. Very briefly, I just wanted to update everyone. We are nearly back to normal, both at Incline Village Community Hospital and Tahoe Forest Hospital, related to resuming of services. We still continue to have an incident command team that has been meeting weekly just to assure that we continue to monitor our CDC guidelines, the state of Nevada guidelines, and the state of California regarding reopening. And again, just assuring that we always look to assure that we provide a safe environment, risk-free environment for our patients, our staff, and our physicians. So we are still meeting, though today we've made a decision to go to every other week, again, because we are really coming back to normal. As normal will be for now, which continues to be wearing masks and social distancing, and we believe we will see that for some time. The other thing I just wanted to mention for those who may or may not be aware, at Incline Village last Friday, we partnered with Washoe County Health District and the North Lake Fire Protection Agency, in which we provided free COVID testing for individuals who were not symptomatic. They were asymptomatic. And in 4 hours, we ended up swabbing about, I think, 295 individuals. So we'll probably take a step back and look and see if the county would like to do that a second time. I hope those who could make it could. We ran out faster than we anticipated. We never thought we would do 300, but it was great to provide that service to the community. And then again, in the Truckee region, the Placer County test site that is located on Donner Pass Road across from the hospital offers Monday through Friday, 7 a.m. to 7 p.m. Free testing for anybody that has symptoms or does not have symptoms. So I just wanted to make sure everybody was aware of that. Thank you, Carly.
Of course, you're welcome. And I'm going to put those links in the everyone chat so you can see how you can get the testing over at Placer County. And we look at it from the office here in Truckee, and they are seeing a lot of activity. So I'm going to pass it over to Sveta Shop now, and she will share her screen and go through a presentation. And she is our infection preventionist, And then maybe Sienna, just give a little bit of background about what you've been doing over COVID, and then you can get right to it. Thank you.
Unmute. Let me share my screen. Can everybody see my screen?
Yep.
Okay. So just to review what we've been doing, just again, thank you for having me on your call. Appreciate it. That I'm able to share some information about COVID with you. Feel free to have questions ready or raise hands, or I know Carly will manage that. We've had a wonderful team of clinicians and leaders as the COVID kept speeding up, and so we will open the command center and created a great team. Everybody had different tasks and responsibilities, worked well as a team to ensure that our employees, healthcare workers, as well as our patients are safe, and making sure that we have enough personal protective equipment, making sure we have solid protocols in place on how we treat patients through emergency room. One of the biggest things that really was helpful to keep everyone safe is to open the drive-up clinic that we had opened back in March. And that is still open, and it's working really, really well. Today, we decided, Carly, Judy, and I met earlier and wanted to kind of push some ideas around what would be interesting for you guys to hear about COVID, in addition to maybe some data. So my presentation is going to be, let's see, advance through the slides. Sorry about that, beginning. There. So what we will discuss today or go over local statistics within our health system, discuss some COVID-19 versus the flu. How do they compare? What are the similarities? What are the differences in how they present, signs and symptoms, treatment, prevention, etc. What is more dangerous? You probably going to be interested in that a little bit. COVID-19 and the flu, what is the disease burden currently? Because we were just finished a month or two ago, technically finished with our flu season for the year. And so CDC has some information on what our overall flu burden of the disease was. And then what are we doing to prepare for flu season? What can we expect as the flu season approaches? How are we going to be prepared in this healthcare facility, as well as in clinics, as well as in Incline Village Community Hospital and clinics there? So these are our local statistic up to date. Currently, Nevada County and Placer County, those are some of the numbers. So the way the first graph really shows, or the table shows, we have totally tested 64 positive patients, or out of our testing, we found there were 64 positive patients throughout the community. Some of these were inpatients, majority were outpatients. Initially, when we started seeing positive tests, which our first positive test resulted that were collected on March 12th, and the last one was actually on May 29th. So between that span of 2.5 months, we've had 64 patients come back positive. Initially, we saw a lot of patients coming from outside the area, some across country, some from outside of the area, California and other states. And then we started seeing more community transmission. So as of the 11th, as I was building this presentation, we had more than 1,200 tests performed at Taos Forest Hospital and 192 cases tests performed at Incline Village Community Hospital. This only includes what we test within our health system. It does not include the free clinics that are available out there. It does not include any other, what other clinics would be commercial labs that people go to. It's anything that's collected in our system. So total, our positive is 64 patients. Our positive rate for overall what we've tested is 4.4%. So one of the regulations that came down the line in last month is to ensure that our long-term care center residents, our SNF unit in Truckee, that they remain safe. So early on in the pandemic, we closed the center to visitors and ensured that there's appropriate PPE available, did a lot of education review for infection prevention practices, which is usually ongoing anyway, but we made sure that everybody was aware of it. And starting at the end of May into first week of June, we tested all of the residents at the SNF unit and they all came back negative. They continue to be having no visitors, and that we continue to evaluate recommendations as they come up. All of our healthcare personnel there came back negative as well for COVID, and now we're just rolling out surveillance testing, what it's called, and that is every week we test about 25% of staff to ensure that we remain COVID-free in that unit. So what are the similarities? Deanna? Yes.
I have a question that came up by someone here. The San Francisco Chronicle this morning said that Placer County experienced a 350% increase. And should we be worried about that? And are you kind of aware of that article or the increase and potentially where those numbers could be driving from? What part of the county?
Yes, so Placer County, as you know, kind of extends from North Tahoe area all the way into more of a valley, Central Valley area. So if you look at the map, there's some maps that really show that there are cases in the North Tahoe area, but a lot of the cases are happening in the southern portion of the county where it's closer to higher populated points. So a lot of the cases are coming from there. As far as that's the way I understand is how their data is reported at the moment. We do test quite a few people that reside in Placer County at the lake, and we haven't seen an increase in cases since March on our end. So that's kind of what I'm seeing is that southern Placer is seeing a lot more cases than northern or eastern Placer, how that looks on the map.
And then one other question, how does Tahoe Forest define community transmission?
Well, community transmission, it's when they do the, so if we find a positive case, and so initially when somebody tests positive, the positive test gets reported to the public health department, and the public health is typically the residents of that person. So if it's a Placer County resident, we would report it to the Placer County public health department, and they do a tracer on that patient to see who they were in contact with and how potentially could they have been infected. So initially we saw a lot of travel related COVID cases. So people went abroad or people traveled to a hot spot within the country as we started to kind of see increase in cases. The community transmission is really becomes obvious is when there's no associated travel to abroad, or there's no associated contacts with people who returned from traveling abroad and had contact with those people. So when you really can't come up with an explanation as to how they could have gotten it, because there's no risk factors associated with exposures. So that's when you say that it's community onset or community transmission is documented. Does that answer the question? Good. All right, so feel free to pipe up again. Let me know, interrupt me. So COVID and the flu similarities. These are kind of busy slides. I wanted you to have information if you want to read it. So COVID in the end, COVID and the flu, and I know some of you may be in a medical profession as a background, and you probably know more, and in a sense that you've researched some of it yourself already. So this may be something more of a review, but overall COVID and the flu tend to be similar in many ways. There's low grade or higher fevers. There's cough associated because it's a respiratory illness. So there's cough associated with it. Some people do get body aches or fatigue. They're very fatigued and they have no energy. Occasionally, some patients do develop, in both situations, do develop some GI symptoms such as vomiting or diarrhea. We continue to compile continue to increase symptoms of what COVID looks like. And CDC has been regularly updating a list of symptoms that we need to be aware of when we're screening these patients for COVID as they come through the drive-up clinic, or they being triaged over the phone for regular appointments or for the clinic appointments. So we regularly update our screening tools and make sure staff have them to ask the correct questions and to screen for the correct symptoms. Both flu and COVID-19 can be mild or severe. With COVID, there is information coming out in many studies that a lot of majority of people really may have no symptoms or mild symptoms to the point where they're not seeking care. And because of that, that could contribute to spread the disease because they are in the communities, they continue to go to work. So on our end, we've implemented symptom screening for our healthcare providers, as well as anybody who is coming to the hospital or clinics, to ensure that we keep people safe. Both diseases can result in pneumonia, and that's a secondary or a complication of those infections. It's fairly normal, and we're seeing that in both cases. So the transmission from person to person, again, is very similar. It's by droplets. So when we talk, when we cough, when we sneeze, when we laugh, we excrete these respiratory droplets. Some of them are small, some of them are little, but normally both flu and COVID is what is determined for COVID, especially, is the droplet transmission. And so that's the reason we ask to have our visitors, our patients, as well as our staff to wear masks. That's called universal mask policy, to contain the source of those secretions. It's very important. So what we tell each other is that I wear a mask to protect you and you wear a mask to protect me. Essentially, we make sure that my secretions don't reach you and vice versa. So both can be spread, of course, by infected person for several days before. Their flu is typically can be spread asymptomatically at about 24 hours before symptom onset. And with COVID, there's various, of course, we're still learning about this. There's various data out there, but typically it says 2 days before symptom onset. And of course, with COVID, the concern of asymptomatic transmission, meaning that those people who don't ever develop symptoms or have very mild symptoms, they could be transmitting it asymptomatically throughout. Differences. So it is determined that COVID spreads more easily than flu. Did I go too far? Yeah, I went too far. And the reason there is determined that way is because there's some data that's out there that's documented that COVID can be spread even on smaller droplets. So how would I explain? The way to explain this, there's aerosol transmissible diseases. It's a concept where there's various diseases out there that we get it through aerosol transmission. And aerosol, we generate aerosol when we talk, cough, speak, laugh, sneeze, things like that. So there's two types of diseases in terms of transmission. There's one is droplet transmission diseases and one is airborne route transmission diseases. And the only difference between the two is that how big are the droplets supposed to be for you to, for the disease to spread. So flu typically a virus has to be in droplet form, which are larger droplets than, let's say, tuberculosis. It's tinier droplets. They can travel farther distances. Typically, we say flu, you need to be safe. You want to be 3 to 6 feet away from other people, from people that are coughing or sneezing. For, let's say, tuberculosis or measles, because the droplets are smaller and they can travel farther distances, even in HVAC systems. What happens with those is we need to make sure that we have appropriate protection. We wear appropriate protection when we're around those patients. Those are called respirators. Make sure that what we're breathing when we care for those people, for those patients, that gets filtered out. And they also have to be in negative pressure rooms. So there is an element of smaller drop transmission and therefore airborne route with COVID. That really has been determined that if we are intubating patients, if they're really ill and they need respiratory support, so we're planning to intubate the patients, then that in itself produces aerosolization. So there's a higher risk for airborne. So there's only certain things that we do to these patients that could cause or increase risk for the airborne route transmission. In terms of cause, I'm kind of jumping around a little bit, but in terms of cause, COVID is, as we know, caused by SARS-CoV-2 virus. Whereas flu, there's several different types of flu. There's influenza A and influenza B, and there's subtypes, and some will mutate. And so when you get the flu shot or flu vaccine every year, you usually, it's called quadrivalent, meaning there are 4 different strains of flu that are in there, and they're dead. Influenza viruses are dead in there, but they just stimulate your body to produce an immune response to the flu. So that's in itself is very different, one virus versus several different viruses and mutated. So other differences, because of the potential for airborne transmission, the COVID-19 does spread a little bit more easily than flu. In terms of incubation time, that is the time from exposure to somebody who has COVID, whether they're symptomatic or have no symptoms, to when you develop first symptoms. Flu is a pretty short incubation period. Between 1 to 2 days is all you need for your body to start exhibiting symptoms. For COVID, it's up to 2 weeks. So it's quite a long time. There's a lot of things that can happen and a lot of exposures can occur if you were to be infected with it and pass it along potentially. This is why there's still recommendation from CDC to ensure that people that travel abroad to self-quarantine or self-isolate at home for 2 weeks, make sure that they don't develop any symptoms of COVID. So some studies also show that COVID, and we've discussed this already about the asymptomatic transmission. So that still continues to be a concern, and hand for the universal mask protocols that everyone has, and even some stores, they don't let you in without a mask. So one of the interesting things COVID may have that some patients have reported is they lose sense of smell and sense of taste, and it takes a while to regain that. There's a small percentage of people develop that, but it's kind of a telltale sign, can be of the COVID. Also, COVID symptoms tend to last longer, up to 3 weeks, and some patients last even longer than that. Compared to flu, usually after 7 days we get over it. Some people have lingering symptoms for longer, maybe up to 2 weeks. So what is the treatment and what is the prevention of the COVID-19 versus the flu? So the treatments. So they are viruses, so therefore we can't treat them with antibiotics unless the patient develops secondary viral or bacterial infections such as pneumonias we really don't have, there's no antibiotics that would work for these viruses. Secondary bacterial infections will be treated. So both are treated based on symptom management. So if there's fever, we're going to reduce fever. If there's congestion, we're going to reduce congestion, et cetera, et cetera. Some patients with severe cases will require hospitalization, and they may require more support, and that is oxygen or IV fluids, or some of them even end up on a mechanical ventilation, intubated. What can we do to prevent this? And this goes very back to basics. And back to basics is really, what do we do to maintain health and make sure that we don't pick up any extra bugs anywhere we go? So we wash our hands frequently. We absolutely have to cover our cough. We do want to stay home when we're sick and limit contact with people who are not infected. This disease does tend to hit people who are older or have comorbidities harder, and that flu does the same thing. Typically, hardest hit populations are older people and people that have comorbidities. So social distancing as well as physical distancing, and that is basically one and the same, can limit spread of COVID in communities. That's why we had a lot of states issue orders of remaining at home and only going in for needed things, you know, if you're purchasing food or needing to go to see a doctor. So as that's being lifted, we do expect to see more COVID cases. And I think some of the numbers are showing that statistically. Treatment and prevention, so continued. COVID, as you probably all know, that there's many medications that are being tested. And again, none of them have been proven ultimately that this is a medication that we're going to treat you with to relieve COVID symptoms or to ease or lessen symptoms of COVID. With flu, we have an advantage. We have Tamiflu that a lot of patients get once we determine that it's flu, or we have high suspicion that it's flu. So that eases the symptoms of COVID or flu, as well as shortens the duration of illness by a couple of 3 days. So that's really helpful. Also,
Vieta?
Yes, ma'am.
Yeah, I have a question about, in the chat box, about remdesivir, and if Tall Forest or Incline has supplies of it, and are we using it to treat COVID?
So remdesivir is, we do not have it available in Truckee or in Incline. And it is distributed throughout the states and ultimately public health departments. I know that they're getting several doses in Nevada County of remdesivir, and it's going to be located, I believe, in their public health department. And if we need it, we could probably request it. I believe hospitals in Reno also have some allocated to them. So from Incline perspective, we would probably, and I don't, Judy and Harry could probably answer that a little bit better. Since I'm not a pharmacist, but they could probably either arrange or transfer the patient down to Reno to one of the hospitals to receive that treatment.
Can I jump in?
And one other question.
Yeah, go ahead.
I just wanted to mention our clinical management team is of our multi-specialty physicians, ranging from our critical care anesthesiologist, primary care, just a group of physicians that meet every week or every other week. And they are putting a protocol related to this. So if we don't have the availability, we will give the options to the patients if they'd like to be transferred, what they'd like to do. So they're putting a whole protocol, because again, that medication is dispersed by the counties. So,
yeah.
Got it. And then another question, are we at liberty to share of those, how many hospitalized did we see for COVID and how many were on ventilators?
yes, we can. I'm going to have to find that information before the end. So, yeah.
I could probably speak to it too, Judy.
Okay, go ahead.
So of the 64 patients that we diagnosed in our health system, we had 10 patients that were inpatients.
At Tahoe Forest Hospital only.
Correct, at Tahoe Forest Hospital only. And I believe we only had one on a ventilator. That was on the ventilator for, I believe, over 2 weeks. But the patient did recover and go home.
That sounds right.
Okay. Any more questions, Carly? Not so far?
Not related to that. We have another question that I'll wait till the end about testing accuracy, and maybe you and Laura can tackle that together.
Okay, great. So moving on to vaccines, obviously it's a huge way of preventing a disease and building herd immunity within our society and our communities. So COVID-19 does not have a vaccine available, although there is multiple, depending on what you read, over 60, over 100, there's various vaccines being tested. There's also very different estimates of when they might be available. Typically to get a vaccine into the general population, it takes, it takes 12 to 18 to 24 months to get that done. So I believe we're still months away from it, but that's one good way, easy way to build that herd immunity and protect people that are most vulnerable by being immune to the virus. With the flu, we have a huge opportunity every year to get vaccinated for flu. So at the bottom of the slide, you can see efficacy rates, and the preliminary rate for the last season was 45%. That's overall efficacy. It does vary by age group and obviously by some other things, like if people have comorbidities or other medical issues. The year before it was only about 30%. The year before that it was 38 and 40%. So it kind of lingers around 20 to 45%. I think the best overall effectiveness was documented at 60%, and that was maybe 10 years ago, if my memory serves me right, from CDC website. So they'll publish updated numbers or final numbers, but at this point in time, it's 45%. The biggest population that benefited from the flu this year seems to be pediatric patients. They had the best response to it, immune response. COVID and the flu, what is more dangerous? Well, we've kind of determined that COVID is more dangerous, and there's several reasons. But because we have no COVID vaccine, and we have no natural immunity in the world or in our communities, so that means that everybody a lot more susceptible to this illness, and it's new to our bodies, and so our bodies may be reacting it completely different than the flu we've had. Every year we get exposed to flu in one way or another. And so since annual flu vaccine is available and it is effective at preventing flu, and it also reduces the severity of the illness. So even if you still get the flu, you may not get it as severe of an illness. You may not develop a severe illness. You may not develop the complications of pneumonia from it. So again, there's no, as we determined, there's no antiviral medications available for COVID-19 at this time. There's various stages of studying those medications that's still in progress. Those clinical trials are still progressing. How much is the COVID-19 deadlier than the flu? There's a lot of talk about it. Currently, flu is typically about 0.1% mortality rate, meaning that 0.1% of people who get the flu die from it. So it's a very small number overall. When we have severe flu seasons, it can go up to a 0.3% sometimes, but overall it's pretty low. The current best estimate for coronavirus, the most optimistic one, is 1%. But we really won't know the mortality rate for the COVID-19 until we are through the pandemic and until data can be evaluated and put in perspective and reported out. Because you probably have seen some numbers If you just do crude calculation of what's available currently for our country versus our states versus the world, I think it varies between 3 and 15% depending where you look at. But again, the data isn't complete and we're not going to really know. We just know that it is deadlier than the flu. So this is a slide I pulled off of CDC, and they had the preliminary burden estimates for the flu for this season. They published back in April. It is not a final information, but not everything that gets reported to the CDC as flu or some of the things don't get reported. They track these illnesses called influenza-like illnesses. And so the estimates for the burden vary. So for example, how many flu illnesses did we have over the last flu season? Well, some estimates say, 39 million on the low end and 56 on the high end. And same thing, medical visits vary based on these predictions or estimates, not predictions. And then hospitalization and deaths. So flu, the worst, what they're estimating, we probably have lost 62,000 people to flu this year. And then this is the current disease burden for COVID. And we're looking, I pulled this off CDC this morning. Some of this information, I know for the states, it kind of trickles in. So it varies a little bit depending where you look. I tried to kind of go off of CDC data, what they're reporting. So we've lost roughly twice so far, twice as many people to COVID since we kind of joined the pandemic, April or February into March. So 116,000 plus people. So there's an interesting number that CDC posts epidemiologically to look at this another way is that cases per 100,000 of population. So overall US is about this number, 635 cases per 100,000. California is a little bit lower, 382. Nevada is actually a little bit better overall than California and better than overall US. In terms of when we break it down to counties, looks like Washoe County is higher than Nevada average and higher than the other two counties that are adjacent to us, Nevada County and Placer County. And in Nevada County, we've had 1 death. In Placer County, we've had 9 deaths. And this is Washoe County. So when you look, there's some maps you look at to see where the concentration of disease is in each county. And the more populated the areas you're looking at, the more disease burden because there's more people intermingling and communicating and hanging out with each other. So there's more disease transmission occurring. Rural areas of each county are seeing a lot less of these numbers. Any questions?
Hey, Spieta.
Yeah.
Yeah, I have a question sort of related to that. And one, I want to recognize that it's 12:47. So for those of you who need to jump off, you can please feel free to do that. We'll stay on for a few more minutes answering questions. We do have a question related to the point that you were just making. And we're seeing, obviously, those of us that live here, we know that tourists are coming. It's been a pretty busy early summer season already. Realtors are telling us that sales market is the most active ever. What are our local hospitals doing for what could be a dramatic increase in COVID infections potentially within the next month? So maybe, I don't know if Judy or Spieta, whoever wants to tackle that together.
So we are still prepared for the increase of cases. We can reopen. We would if we have a dramatic increase, we would open a COVID specific unit where we get those patients. And if we need to increase in testing, it would probably be test supply dependent. But we do have the free testing available as well in both areas, both counties. We continue to meet, as Judy mentioned, less time from this week forward as an incident command. So we are prepared. We continue to monitor our personal protective equipment, our supplies, make sure that we have enough. We continue to be diligent and judicial about how we use those. So I would have to say that right now, if we see increase in cases, we are prepared to handle it. Judy, would you like to add anything else?
Yeah, I just want everyone to know, besides being prepared, we still have the resources we had available in those processes. We do have a team that is beginning to meet this week in anticipation that in the fall, winter, we'll have a resurge. And how do we put back in place, or how do we improve what we did before? So we are putting a plan together for that resurge in the fall.
Okay, great. And then another question, this is, I think for Laura, this is for you. What is the specificity and sensitivity of the test? AKA, what is the accuracy? What are we seeing in terms of, you know, potentially false negatives and things like that? And Laura, you might have to unmute yourself just as an FYI.
So that's a *6, right?
Yeah, if she's on the phone,
Okay.
but I see her name.
Oh, I think I got it now.
Thank you.
There you go.
Hi there.
Laura, thank you.
Hi all. Sorry, I don't have a camera. You don't get to see my beautiful office. It's not as beautiful as Carly's office. But
Hey.
yeah, for testing, couple of things. One thing I just want to say is that no lab test is 100%. And years go into validating lab tests. All the things reported from our labs right now have been validated extensively and have been verified by outside agencies. None of that has happened with any of the COVID tests. We just didn't have the time. We really had to get them out there as soon as possible. So that being said, the tests that are performed for COVID at our state labs in Nevada and in California, it's this test from the CDC, and it is extremely sensitive. I've been told it can detect as low as 5 virus particles. It's a really good test, and it's very specific because it is looking for the nuclear material, the molecular material in the virus itself. Some of the things we do here with false negatives, it's a difficult specimen to collect. It's fairly painful and really have to get back there in the nasal cavity. So specimen collection procedures can result in a false negative. Another thing that's been looked at is that we feel the virus may move from the nose down right into the lungs, and at some point in the disease, it may no longer be detected from the nasopharynx and is down into the lungs. And we have seen that with some of our patients here, even in the hospital, where a specimen more from the lungs did come up positive after a negative test with a nasopharyngeal. So that being said, I also want to throw in, we are very excited to be able to perform COVID molecular testing at our Incline lab. And this was with the generosity of the state of Nevada. Washoe County has given us test kits to perform that test. And you may hear some things, there are questions about the sensitivity of this test. It's not as sensitive as what we have down at the state lab, but also the state lab takes 5 to 7 days to get our results back. So there is a trade-off there. But we are also taking action along with the vendor to try to improve the sensitivity of that test. We're no longer sticking the specimens in a transport media, which we felt may have been diluting it. We're actually running the swab directly as soon as it's collected to help improve that sensitivity. Does that answer your question? Anything else?
Absolutely. Absolutely. Thank you so much. I don't have any, Vieta, was there anything else that you wanted to cover kind of before we end? Or if anybody has any questions, please put them in the chat box, or you can certainly use the reaction feature and raise your hand, or actually raise your hand at me and I'll unmute you if you have questions before we move on. Vieta, anything in conclusion?
The only thing I wanted to share with you, let's see if I can advance my slides, is how we're preparing. And what I would encourage all of you and your families, get vaccinated when the flu vaccine is available. There is some projections that COVID could, we could see increase in COVID concurrently with flu season. We will continue as a facility, we're continuing with universal mask protocol to keep everyone safe. Am I going backwards? And continue with high social distancing as well as mask. So one last slide ahead, there's probably a lot of questions of how effective are the masks. So there's some universities recently have done some studies, and this is what was published, and that is basically shows effectiveness of how effective our masks are. So what we normally use in the hospital setting are N95, which is a respirator type mask, and it's used for airborne illnesses, including for those patients who are suspected to have COVID or confirmed COVID. And it's a 95% effective, and it's a respirator. And then surgical mask, because it's a looser fitting item, could vary from 60 to 80% effectiveness. Then they had tested other fabrics and materials. And obviously you're not gonna walk around with a furnace filter on your face, but it is 75% effective. So the cotton bandana, which is the 4-layer or 2-layer, you could probably equate typically, if you make your own mask, like a cloth covering, it's about 20% effective. So the lesson from the slide is really just, if you have some covering is better than nothing, no covering.
Hey, Sienna, what about those face shields? Do you have effectiveness of those?
Face shields prevent the droplets landing in your eyes or on your face, and then you touch your face later and scratch your nose or pick your teeth, and then it's in your mouth, and you're shedding your lacrimal ducts, which is shed your tears. They kind of go in the back of your throat, and so there's that theory that, you know, you can get infected that way. So the face shields are helpful, but also people should wear some sort of a mask in addition to the face shield.
Great.
I'm sorry
any
it took so much of your time.
Oh, no, that was absolutely wonderful. I think if if people had to go, they would have gone, so that we're still here. But any other questions, you can unmute yourself now, or you can put it in the chat box. I do believe I've captured everything in the chat box. Ooh, nice slide. I like it, Sienna. So now is your time. Otherwise, we certainly thank you for your time here. Thank you for what you've done for our health system. And it's really helped us prepare, respond, and certainly we hope recover from COVID-19. So we truly appreciate it. Oh, here you go, Sienna. Why would you want to get tested if you don't have symptoms?
You would want to get tested if you don't have symptoms if you are in contact with other people who are more susceptible to virus or could have worse outcomes from it, such as if somebody's on chemotherapy. Of course, testing it today versus testing tomorrow could have different results, because there is a lot of people that don't have symptoms. So you could be tested if you're shedding virus today and you're not, but a week later you could be tested and you are shedding virus, still asymptomatic. So it's kind of a dicey situation, but the reason you'd want to figure out if you're positive is if you're in contact with vulnerable populations. And that's what we're doing in the extended care center. Our SNF unit is we're testing staff to make sure they're not positive when they're working with those residents.
And when we are reporting our numbers, Sienna, is that based on a patient's full-time or primary residence, or where they are hospitalized or tested?
So if a patient, let's say, traveled from Sacramento County somewhere and they're here, we will be reporting it to Nevada County, but then either Nevada County or us will be calling Sacramento County and reporting. The way the county or public health is reporting this is they report based on the residence status of the patient. So we will, we're keeping track of those patients on our end, of course, but public reporting is what you're seeing in the communities. That is based on, even if I'm in Tahoe, but I live in Sacramento and I'm tested positive in Tahoe, my public health department in Sacramento will be reporting the numbers. Does that answer it?
Okay.
Okay.
Yeah, I believe so. And is there anything that the hospital can do to promote mask wearing in the community?
We've done education. We continue to do education with patients as they come through. If people think that we could do more education in the community, we certainly can continue working on that. But mask wearing is, again, it's a very, very important step in preventing transmission. Even if it is cloth mask, we're still filtering out some of those droplets. It's better chance of not passing it on than not wearing a mask.
And if someone was ill months ago, are they still showing any symptoms?
So there's studies that have been done, and they show that the shedding of the virus could happen up to 40 days, 50 days, some of them just various information out there. But what they discovered, there's other studies been done, shedding of the virus doesn't mean that you're infectious necessarily, because you could be shedding particles of virus that are not infectious, or it's not infectious any longer, but you're still just kind of shedding it out of your system through secretions. When we test, and Laura, please chime in if you want to, but when we initially test for COVID, we are testing to see if people have virus in their system, if they're shedding it. But that test does not tell us if the virus is alive or dead. We're just seeing if you're shedding it, if it's in our lungs. They've also done studies where concurrently with the viral DNA testing, they're collecting specimens and growing out viral cultures to see if whatever we are shedding can actually reproduce itself, essentially being infectious. And after 10 days, they've noticed in one study, after 10 days, they've noticed that the specimens no longer can produce viral cultures. That means what it's telling us is that from the time the onset of symptoms till the time you're finished being infectious or can transmit that virus to other people is about 10 days. So after 10 days, even though you may be shedding, you're no longer infectious. But that also depends on not just that specifically timeline. We want to make sure that the symptoms are resolving. We want to make sure there's no fever for at least 3 days. There's other components that go into effect before people are released from isolation to make sure they're safe to join the community.
That's the last one I have.
Okay. Thank you very much for your attention, everyone, and your support of our hospital. Thank you.
Thank you.
Thank you so much, Fieta. That was great. Thank you, everybody. Nice to see you all.
Bye.
Bye. Thank you so much. I'm going to stop recording.